Welcome everyone here this evening. We're starting a little bit later than usual, but we do have a packed agenda. So I would like to call this meeting to order. Today is Wednesday, August the 8th, 2018, and it is 6:28 p.m. I would like to call to order the meeting of the Central Health Board of Managers Budget and Finance Committee. If there's no objection, the agenda items will be taken in the following order: 1, 2, 3, 5, 7, 6, 4, 9, 10, and 11. Item 8 will not be discussed, and it is discuss and take appropriate action on Central Health-owned property, including the downtown campus and adjacent property. Did everybody get that?
Can you repeat that one more time, please?
The agenda item numbers: 1, 2, 3, 5, 7, 6, 4, 9, 10, and 11. Okay. So, I would like to place the first item on the table, approve the minutes of the following meeting of the Central Health Board of Managers Budget and Finance Committee, July 17th, 2018. Do I have a motion?
I'd like to move that we adopt the minutes for the July 17, 2018 Budget and Finance meeting. Second.
I have a motion by Manager Valadez. I have a second by Manager Greenberg. Any discussion? All in favor?
Aye.
Any opposed? Any abstaining? Motion carries. Item number 2, discuss and take appropriate action on the amendment agreement between Community Care Collaborative and iPhysicians of Austin. It will be presented by John Margan and Dr. Mark. Thank you very much for joining us.
Good evening.
And you can,
Great. There are no slides for this item or for the next item,
okay?
but I would direct your attention to the memo that was included in your backup packet. Tonight we have a request for additional funding, 2 of our initiatives that are related to service expansions that we started back in 2017, in fiscal year 2017. One is a service network expansion related to specialty care in the area of ophthalmology. The other is related to an important piece of our system in the post-acute spectrum of care and the hospice services that we provide for our patients. So as you all know, we started these expansion efforts about 2 years ago. This is the first year of full operations for these items. And as a result, we monitor the utilization over the course of the year, and we have gotten to a point at this point in the year that we have exhausted or project to exhaust our funding available for these 2 service initiatives. So for ophthalmology, just to speak to that for a second, we've had a long-standing relationship, a provider in the community that served our population for years and years, Dr. Richard Briggs, and he's always done a fantastic job serving our patients. Back in 2017, we expanded our network for general ophthalmology to include iPhysicians of Austin. That agreement has gone very well for us. That partnership has gone very well for us. And I'm happy to share that after a year and a half of good work on the part of our staff and that new provider group in collaboration with Dr. Briggs, we've been able to eliminate the wait list related to MAP patients for general ophthalmology. We're very happy with that progress. Like I said, very happy with the partnership. The way that we budget for these items is we try to give ourselves a pilot budget or a starter budget, and then based on actual utilization, we'll add funding over the course of the year. Earlier this year, we added with administrative authority $100,000 to take our total contract amount to $200,000. We expect that we're going to need an additional $100,000 to get us through the end of this fiscal year. So the request tonight related to Eye Physicians of Austin is to increase by $100,000 for a total of $300,000 in this fiscal year. And then we'll be carrying that dollar amount forward. You'll see later tonight that dollar amount rolls forward into fiscal year 19 into that budget. We anticipate that we're going to continue to have that level of service. With Hospice Austin, that, like I mentioned, is a new service for us. One of the things that we do in the CCC, as you'll see in our strategic plan later tonight, is to really put the pieces in place that we need for the integrated delivery system in Travis County for the safety net population. One of those pieces that has long not been available for our patient population is hospice services. So back in 2017, we partnered with Hospice Austin to expand the availability of services that are available for our patients. For a long time, Hospice Austin has provided a level of charity care, and the addition of our funding related to MAP patients allows them to extend that farther for the uninsured population. As a result of the funding that's made available through the CCC budget, MAP patients have access to the same the same hospice beds at the Christopher House that any other patient would have. In addition, we've added the home-based hospice services for our patients, which is another very valuable service for us. Since the
Could you pause for just a moment, Counselor?
So I needed to read agenda item number
Yes,
3
I
as
was
well.
just thinking about
sorry,
that.
I thought we took them up together. My apologies.
No, I did not lay them both out. We'll also be taking up agenda item number 3, discuss and take appropriate action on an amendment to the agreement between Community Care Collaborative and Hospice Austin. Okay.
Thank you. Sorry about that.
That's all right.
So far this fiscal year, 66 of our MAP patients have had access to those valuable services from Hospice Austin. And since the beginning of our pilot back in 2017, over 100 of our patients and their family members have benefited from these services. So we're excited to continue them. Our new DSRIP program also emphasizes hospice services and the availability of those services to our community. So we're very excited about both of these partnerships, and we're excited to continue reporting to you all going into 2019 on our progress. Happy to take questions.
Thank you, John.
Anything?
Madam?
No, you can go ahead.
Oh, okay. I have a specific question about the hospice services, having recently had experience with this in Austin not necessarily Hospice Austin, but with hospice, home-based hospice care. Is there the capacity? This is essential for the patients we serve, particularly those at 200% below of FPL, to not just have those hospice beds, but to have that in-home hospice care. And does Hospice Austin have the capacity?
Yes, absolutely. They were limited in their ability to serve the uninsured population in Travis County, and the addition of our funding allows us to cover the full need for the MAP population. And then they're able to use their other resources to help serve the uninsured population that's not involved in the MAP program.
Again, do we know their current capacity, for instance, as far as nurses and whatnot, and what they will be adding to serve our population? My experience has been with the home-based hospice. I know we have all kinds of nursing shortages in Austin, and I have certainly witnessed that there's been a shortage with the nursing, having enough nurses with the home-based hospice. In general, not Hospice Austin.
We have not had a MAP patient that has needed hospice services that has not been able to access those services.
Well, I'm going to press this because I would like some data on, for instance, with the home-based hospice care, how often are those nurses going to visit at the home of these patients, and some of this data? I think it would be helpful to see that, to have an understanding of what's being provided.
Happy to provide more information on
And
that.
does the full board want that? I don't know, or is it just me?
No, I think that would be excellent information
Okay,
to
so
inform
if you
our
could, yes.
understanding of the service.
Exactly. I just don't think I can have a full understanding of what we're providing without that kind of data.
Understood.
Thank you. Madam and then Shannon.
Well, thank you both. I have a couple of questions. First of all, related to hospice, how many have we served and at what stage do you normally consult them? You know, I always say it's quality over quantity of life. And so when do you providers, when do they have access to it? That's number one. So if you want to answer that first. And my other question could be probably going back to the chair, where would this funding for both items come out of? Which pocket?
I'm going to refer that to Jeff.
Sure, so for the funding question, it's gonna come, the CCC has contingency funding, and
So it
that's
will
where
be coming out of,
coming out of contingency funding.
okay.
We have a $3.6 million operating contingency in our current year budget. That's where we draw from when we come up against the contract.
Thank you, and if you can follow up on that hospice.
Yeah, so on the first question, I would offer that there is not, we don't place a requirement that says you can get in at this point or you can get in only after this point. It is a clinical decision that a patient's family and a physician come to jointly. I would say that when we started this, because most patients didn't have availability, bear in mind, the only hospice services that they could get were those that were offered purely charitably by Hospice Austin, which meant there was a severe limitation on the number of services that could be provided. The tendency was for physicians not to refer, knowing that in general, I'm going to make this referral and nobody's going to hear me. Nobody's going to be able to do anything with this referral. And so, generally speaking, referrals were made too late. So it is of little consequence. Let me rephrase. If one is terminal, it is a comfort to that person to refer them to hospice in the last 48 hours of their life. It is a much better comfort to have identified that their progression of disease was downward 6 months or 9 months prior to their demise and to have enrolled them in hospice at that point. And so I do think through this program and being able to bring funds to bear for our MAP patients, we've seen a lengthening of the number of days that patients spend in hospice services. And one wouldn't normally think a lengthening number would be a good quality indicator, but in hospice, it absolutely is a good quality indicator because it represents the fact that we are identifying patients upstream at a stage where we can actually intervene and provide a higher quality of life. And so, again, there's not a line in the sand. It is individual based on the patient's family and the provider conversation. I do think because we've made these funds available and made this service available to our patients, providers now recognize earlier, I can help. And I can help because I can make this referral. And there is funding available so that this can happen, as opposed to waiting to the very late stages when the only thing we can offer is a couple of days in Christopher House before somebody finally dies.
If there's a bed.
And so that's basically how I would answer.
So how many have we funded? Have we,
So we
66
and
fiscal year?
can you give me the length of time? I'm just trying to get an idea.
Again, we can bring those numbers similar to Manager
It'll be
Greenberg's
helpful to know
request.
at
We
what
can
stage
bring you
and
that.
How long they've been receiving it. Well, thank you.
Thank you very much. Shannon?
My question is more on the item number 2, so are we taking questions? as
Yes,
well?
yeah, both items are on the floor.
Okay, I'm just interested, I just read and heard yesterday about ophthalmology versus optometrist services. And the question is whether or not, and I think they're looking at state law as to whether or not optometrists can perform the duties or most of the duties that are performed by ophthalmologists. I'm just wondering, and I don't know if this is a question for you, Dr. Hernandez, or not. One, is there I would imagine there's a cost differential in terms of service level. And if so, what is your thoughts on, if we get to that point, would it be better if the state is considering allowing optometrists to do some of the level of service? Would that benefit our population?
So I think if the state of Texas changes law to say that a particular professional can provide services that they previously could not provide services. We would want to evaluate the qualifications of said individuals that wanted to provide services to our patients, i.e. they need to be credentialed, they have to go through credentialing processes and those sorts of things. But given, I'm given the notion that they successfully passed credentialing and it is now legal for them to be engaged in that sort of care, I don't see any reasons why we wouldn't take advantage of a changed regulatory environment for those providers. And yes, your question is a good one. Optometrists are less highly paid than ophthalmologists. It reflects the difference in training. Optometrists are primarily involved in vision, which it seems obvious if you're dealing with eyes, you're dealing with vision. But they specifically practice in the space of vision. Ophthalmologists practice in the space of all diseases of the eye and surrounding structures. Ophthalmologists are surgeons. Optometrists are not. So if you needed somebody's cataract removed, optometrists are not doing cataract removal. If you needed somebody to diagnose some sort of foreign body, so, you get a splinter because you're out there sawing logs in your backyard. If that lives inside of the scope of practice for optometrists, then they certainly can get some tweezers and pluck something out of somebody's eye, and that's okay. But they wouldn't be removing cataracts or doing other sorts of advanced procedures. You need ophthalmologists for that, so.
So to my question, which goes back to the question is, the nature of the clients that we're seeing, would they benefit more from the ophthalmologist and the optometrist?
We have kind of three groups of people that see our eye specialists. We've got people who have cataracts. It is by far the most common operative procedure that occurs in our population. For that, you need ophthalmologists. We have another bucket of people who have general eye complaints, some of which require a surgeon and some of which would not. Those people would be assisted by an optometrist. And then we have everybody who has diabetes in our population who needs routine screening for retinal eye disease. We've got that handled with cameras and other sorts of modalities, but then once you diagnose them with retinal eye disease, you need a retinal specialist. That's an ophthalmologist. And so is there some opportunity for our population? Absolutely. Is it the whole bucket? No, it's not.
That's it, thank you.
Thanks, Shannon. Cynthia was first, and then I'll go to you, Sherry.
I apologize for not hearing the bulk of your comments, but I just wanted to know if anybody asked any questions specific to hospice with respect to who has received hospice care and where did they actually live? And I think the reason I'm asking that is because I originally asked the question, I'm talking about, our population tends to be located east of 35 and maybe the Runberg or Dove Springs or South area. And from what I could tell initially when we originally approved the hospice contract, after Trish left, was that most of those facilities were west of 35.
So we do business with one company, Hospice Austin. Hospice Austin has a facility, an inpatient hospice called Christopher House
Yes,
that is
that's right.
on MLK east of 35.
I've been there.
They have corporate offices and a physician's office that is on Spicewood Springs, a little bit west of Mopac. And the rest of the services that we buy from them are in the homes.
Okay.
So we're certain, nobody asked the question you just asked. Merrim asked a question that was similar but not the identical question. We can certainly provide you, I think, somebody will yell at me if we can't, but I would think we could certainly provide you data on who we've taken care of. That was a question kind of shared with Merrim. And where they live in terms of kind of where
By
they.
zip code.
By zip code,
We wanna
provided
start-
that
we wanna
doesn't
start
get me in
driving
trouble
the
with the
zip
HIPAA police. So the HIPAA police get to weigh into that conversation, but if they don't tell me no, we're happy to provide that to you. I think what we'll find, so this is Mark's prediction, and we'll see if I'm right, is we'll find that they come from the places where MAP patients traditionally live. And so where we have high concentrations of individuals who have MAP, you're going to see our high concentrations of hospice patients coming from those same spaces. I don't think that we'll find anything surprising in our data. Lots of folks live in East Austin, lots of people live in the northern part of the county, and I think that's where our hospice population is going to be drawn from, because that's where our density of population is. We're happy to find that, though.
So by zip code is what I'm looking for, okay?
And like I say, if we can provide it to you, the problem is if I have one patient in a zip code, the police tells me I can't tell
that's
anybody
right.
that because it becomes potentially identifiable.
Correct.
And so it just depends on how the data plays out. We only have 66 in the group.
Yep,
So it's possible you're going to have a zip code where there's only one person, and that kind of limits our ability to talk about the data.
And with respect, I'm so glad that we're offering hospice for children. I live in that world, could have lived in that world, and I'm glad I don't. But one of the things that benefited our family greatly was the access to grief counseling. And I was wondering whether or not grief counseling is actually part of this process.
So it's part of the package of hospice services that are provided. It's bundled in the payments that we make to Hospice Austin. So they provide the same services to our patient that they would provide to any commercial payer patient, to any Medicare patient. We don't get a different package of services for our patients than they give to anybody else.
Okay, and that's provided to the entire family, correct?
If that's their practice, which I'm pretty sure it is.
Well, I hope so. If that would be something that needs to be asked, then could you please ask it to make sure that it is provided to the entire family? Because what I've seen, what I'm familiar with is a program that's offered in Dallas. And that through the grief process, through the grieving counseling that the children, separate from the parents, receive, you will see how children act out very differently from adults. And they impact those in the schools, and they're identifiers. And so I just want to make sure that we do offer or that somebody's offering that kind of service. Okay? Because that's.
Thank you, Manager.
Thank you.
Ms. Greenberg.
So I don't know exactly, and I'm sure you'll find out, having recently gone through this. I know the social worker came and asked, who are the people who are going to need this grief counseling?
Janet.
As to your question, just a little context, this discussion of the ophthalmologist and the optometrist, and I think it's called scope of practice, has been around for a long time. And it was a significant issue in the mid-90s that some of us were subjected to. It's a continuing issue. My experience has been that this issue tends to surface around what I would call the margins, because clearly the physician has answered that there are some things that are clearly eye surgery, versus vision. But there are others that seem to be this gray area that keeps surfacing, such as if there's an eye drop that's prescription that needs to be prescribed and those kinds of things.
Definitely. All right, any other questions? Julie.
And this kind of goes back to it's budgeting season, and I think I posed this last year. How are we just kind of giving contracts again and again and again to the same providers, or is there some way of saying, hey, there's competition in this area, can we get the best price for it? Because I mean, and that's going to be my question for y'all in the budget. So just so y'all are,
And a response is not the full response, but I'll just toss it out here now since you asked. I think one of the challenges is that traditionally there have been groups in town that see themselves as safety net providers. The CEO, one of those, is sitting back there behind me. And then there are many practices in town that have never seen themselves as safety net providers and don't play in the space. That is changing slowly. And so as that changes, we definitely reach out to new provider groups that haven't traditionally been associated with the safety net. We had a very good conversation with a surgeon last week that looks promising. And so we are continuing to have those conversations with the understanding that progress comes slowly there. And those groups that have often been able to negotiate very good contracts with payers have to have a reason to want to take what is a less favorable contract with us, and we're trying to be good stewards of the dollar. So I would offer that. Hospice Austin is unique and is not unique. So around the question of can they provide enough service, which is
What I asked, the data, what
what
is-
Sherry was asking, what I would say is that they both had the inpatient hospice and were already providing charitable care to this population before we came around.
Right.
That made them a very aligned possible partner for us, which is how we ended up in contracts with them. I do think at some point we will have to talk to other hospice companies, but to my understanding, there are no other hospice companies in town that are not for profit.
That's right.
Every
That's
other
right.
hospice company in town is a for-profit
in there.
company or is a subsidiary of a for-profit company. And it doesn't mean we won't go talk to them. It does mean we may not find alignment with them. And so to the extent we can continue to expand the network so that we can get competitive pricing, you should hold us to that, and we should continue to do that.
Mine was more in the area of ophthalmology.
Yeah, ophthalmology. And
If I could just
Yeah.
add to what Mark said, we're always interested in working with new providers that are interested in working with our patient population. To Mark's point, alignment for us is about more than price, even though from a pricing perspective, I think we're doing very well in ophthalmology. And the other thing I'd add is with all of our service delivery contracts, they're all reevaluated annually as part of our budget development process. And we make amendments and tweak those contracts and add new ones and terminate every year. So you'll see more of that in our budget conversation as well.
So I said, spoiler alert.
Yeah, sure. No, for both of these, absolutely.
Is that it? Thank you very much. We had 5 minutes allotted. We're in 15 minutes. Thank you very much.
Talk to him offline.
2 words.
Very short.
In addition to the grief counseling, culturally competent, linguistically competent grief counseling. Because each culture has a different way of dealing with death or rebirth. Thank you.
Thank you very much. I'm going to take these, thank you guys, I appreciate it. I'm going to take these items separately, so I need a motion for agenda item number 2. Madam?
I move that the committee recommend the board approve and direct the central health appointee to the Community Care Collaborative Board of Directors to approve an amendment to increase the not-to-exceed amount from $200,000 to $300,000 for the agreement between the Community Care Collaborative and I Physicians of Austin to maintain ophthalmology services through the end of fiscal year 2018.
Okay.
And I have a motion by Manager Musaitif. I have a second by Manager Greenberg. Any discussion? Okay, all in favor?
Aye.
Any opposed? Any abstaining? Motion carries. Item number 3, I need a motion. Manager Greenberg?
I move that the committee recommend the board approve and direct the central health appointees to the Community Care Collaborative Board of Directors to approve an amendment to increase the not-to-exceed amount from $500,000 to $725,000 for the agreement between the Community Care Collaborative and Hospice Austin to maintain hospice services through the end of fiscal year 2018.
Do I have a second? I have a motion by Manager Greenberg. I have a second by Manager Aiken. Any discussion? All in favor?
Aye.
Any opposed? Any abstaining? Motion carries. Thank you again. Appreciate it. Okay. We're going to take up agenda item number 5 on page 13 of your packet. Receive and discuss an update from the Dell Medical School at the University of Texas at Austin on the value of the investment in and partnership with the Dell Medical School. And we have Monica and we have guests. You might want to introduce yourselves.
Actually, Monica's going to tee this up.
Are you going to tee this up for us, Monica? Thank you very much.
Crowley from Central Health Chief Strategy Officer, and I'd like to introduce Elizabeth Colvin, Dr. Rebecca
Rogers.
Becky Rogers, and Dr. Mike Pignone from the Dell Medical School, and they're here tonight to present on work that's happened in the past year and things that are upcoming as part of their work to support Central Health.
Thank you. Welcome. Thank you for coming tonight.
So I will begin tonight. Elizabeth Colvin. I am here in my very new role as Director of Local Affairs for Dell Medical School. Clay and Minnie would like to be here tonight, but neither of them are in Austin to be able to talk to you. However, I'm very glad to have Mike and Rebecca here to share about the programs they've been working on. We saw the purpose of this presentation is to communicate the impact the medical school has had in the community and also how the work we're doing aligns with the objectives and strategies of Central Health for fiscal year 2019. As a starting point, I think it's important to look at how far we've come in a very short period of time. Proposition 1, which is what was the very first step in starting a medical school, was passed in November 2012. Dean Clay Johnston was announced in March of 2014. The very first medical school started in the summer of 2016. Now, just 6 years later, after that first initial step, we have our third medical class starting, and we've opened 5 subspecialty clinics that were selected based on specific needs in Austin. We've also had some remarkable projects in partnership with other people in Austin and other groups in Austin that have impacted and improved healthcare for low-income and uninsured families in Austin. To me, really the best example of one of those projects is the elimination of the 12-month wait for MAP patients to get orthopedic care. If you have been on this board for a while or you worked with MAP patients a few years ago, you know that that very long wait for MAP patients with back, hip, or knee pain was a source of tremendous frustration in this community. And now those patients can get orthopedic care within 2 weeks. So that's a good example of one of the collaborative projects where DelMed has made a significant impact on the population served by Central Health. So I'd like to focus on your objectives and strategies. You have 2 documents in front of you. One's a sort of one-pager on the 3 ways we can create impact, and then you have a brochure that goes into more detail on different DelMed projects. If you look at the new clinics that DelMed has created, those are in line with your strategy 1.1 on service location and care delivery, and also 2.1 on improving network adequacy for access to primary and specialty care services. The clinics that were opened were based on needs in Austin. They include women's health, musculoskeletal, and neuroscience. And within 7 months of opening, these clinics had served more than 2,000 MAP patients, or that had more than 2,000 visits from MAP patients. And that really goes to your objective 1, that Dell Medical is helping Central Health deliver needed specialty care to Central Health's target population with the number of MAP patients that are being served at these clinics. In further support of those strategies, DelMed will be opening even more clinical programs. Some of the priorities being discussed are an ambulatory surgery center and GI services. And Mike will also be able to talk tonight about a primary care clinic that will be opening this month. Dell Medical is also launching a world-class pediatric and congenital heart disease program. Dr. Frazier, who started the lead program in the country, had his first surgery in Austin very recently on an adorable 5-month-old. There was a feature story on the television. And that story really communicated a very important fact, that it's important to think of this program from the perspective of those families whose children are born with a very serious heart condition. And the fact that those families can now stay in Austin and have this expert level of care for their infant and not have the burden of having to travel elsewhere. That demonstrates how families are benefiting from this expertise that Dell Medical is able to bring to Austin because we now have a medical school. Another one of your strategies focuses on the social determinants of health. And the medical school has a whole population health department and a Center for Place-Based Initiatives, which you may be familiar with, which does a regular call out to the community to get grassroots solutions that often focus on these social determinants of health, which is very much in line with Central Health strategies. Another example of this is a partnership that DelMed had with People's Community, which has been doing amazing services in Austin for a very long time. They came to DelMed with a very specific need to be able to track environmental and other social determinant factors in a way that physicians could use that information along with traditional health data in asthma care for children. So DelMed was able to bring that expertise to the table to create a data tool that could incorporate those social determinants and help peoples do what they do so well in caring for these children. For your second objective on implementing patient-focused and a coordinated healthcare system, I think the best illustration of that is our clinics. If you have not yet toured our clinics, I would encourage you to do so. Just the physical layout, the design, the whole flow for the patient is patient-centered and team-oriented, where the team is coordinated around the patients. If you haven't toured, we will be hosting another tour for Central Health board members in August, and I would hope you will join us. And just seeing it is the best way to communicate how DelMed is bringing that to the forefront. And Mike and Rebecca can also talk about their work around that patient-focused and coordinated care in the projects they've been doing. We really see this year as a pivot point for DelMed, where we've previously been focused on creating the infrastructure, recruiting, developing models, and now we can pivot to bringing innovative services that are benefiting people in Austin. And we see this will continue to progress as the medical school grows, as we graduate classes and recruit more residents. So it really is a critical point in the history of the medical school that Austin is greatly benefiting from. And you can see that in our allocation, which is another document that Monica shared with you, how our allocation is shifting to focus on those clinical services that provide direct benefits to MAP patients and others in our community. So I'd now like for Mike to share about his program, and then Rebecca will also share.
Thanks, Elizabeth. Thank you all for having us here today and giving us an opportunity to present our work. My name is Mike Pignoni. I'm the chair of internal medicine at Dell Medical School. I came here 2 years ago from the University of North Carolina, where I'd spent my whole career, 20 years up till then. And the reason I came here was really the opportunity that you all have afforded us to build a world-class medical school that is rooted firmly in the community. And I think we've made a great deal of progress up to this point. We have our third class coming in, as Elizabeth said, but we still have much more to do to really build, to fulfill the promise of making Austin, the city with the best health equity, in the country. That's really my goal in internal medicine. The program I'm going to talk to you about today is one of the first things that we got going here. I have a long background in colorectal cancer screening. I've done research on that topic for really my whole career. And Austin and Travis County, like many other communities, suffers from inequities in colorectal cancer screening. Insured populations are doing quite well. Most adults ages 50 to 75, which is the target age range, are getting served, getting screened. But our poorly insured population or uninsured population, those rates are much lower. So for instance, in Our community care partners, clinics, the screening rate is only in the 25 to 30% range, and that's true of most community health centers in the United States. So we embarked in partnership with community care, our partners at CCC, Mark and John have been great partners in this work as well, to develop a program to improve the colorectal cancer screening rates. We were fortunate enough to apply for and receive a grant from the Cancer Prevention Research Institute of Texas, the state program, for $2.3 million, specifically to improve colorectal cancer screening over a 3-year period of time. We're about 9 months into that first year, and the program that we've developed uses mailing out colorectal cancer screening tests to people who we believe are not up to date with screening in the community care system. That program is going very well. It's paired with patient navigation, bilingual patient navigation offered from our community care partners' offices to help people complete those tests and prevent, hopefully, or catch at an early stage colorectal cancer, thus reducing the burden of morbidity and mortality. I think it's a good program, firstly and most importantly, because it has the opportunity to improve the health of people in Austin and Travis County. But it's also, I think, a good program because it illustrates how an academic partner can help leverage resources that might not have been available otherwise. We brought expertise to bear that helped us win that grant. It's a competitive process. Everybody in Texas wants that money. And it was a good thing for us to be successful in that realm. We hope to do that in other areas. It also offers a great learning opportunity for our students, residents, allied providers at UT Austin to learn in service. So we've engaged a number of our learners in the work. They bring a great deal of energy and also learning what it means to produce health equity in the community here. So we're really excited about that as well, and about all the future possibilities. So thank you all for making that opportunity available to us. Elizabeth asked me to also note that we are building services in other areas, including in primary care and medical specialty care. So it's going to be a continuing year of great growth, but also even more direct care to the patient population.
So I'm Rebecca Rogers. I'm a OB/GYN with subspecialty training in urogynecology. Some of you might not know what that is, but I specialize in taking care of women with pelvic floor problems, so incontinence or prolapse, pain, surgical misadventures, things like that. I came here from Albuquerque, New Mexico. I had spent my career at the University of New Mexico and was recruited here to be the Associate Chair for Clinical Integration and Operations, which is a long title, but means really trying to put the wheels on the road in terms of operationalizing programs and developing our service to the community of Travis County. I'd like to just take a minute to highlight two areas where this work has happened. One has to do with focusing efforts on reducing and addressing the opioid crisis. As you know, this is a huge national problem, and we are not immune in Texas, and certainly not immune in Travis County. And unfortunately, in the medical profession, we used to think, well, if you were given opioids because you had, let's say, a cesarean delivery or you had a surgery, that was really no big deal. That didn't really put you at risk for long-term abuse. We now know that that is not true. And if you look at some literature would say up to 6% risk of a chronic opioid problem, even with a single exposure. Now, the rates typically are a little bit lower, but there are reports as high as that. So we take that very seriously. We certainly don't want our moms, we want them to have safe deliveries without developing other problems. And we noticed that patients were being given fairly high doses of opioids around delivery if they had a cesarean delivery, or let's say they had a bad tear or something like that. And certainly not out of keeping with the rest of the country, but being sort of an older OB/GYN, I remember when we really didn't give opioids, so it's a surprising creep in how we treat patients. So working with our docs, operationalizing through where our patients are delivered now at Seton, Maine, the majority of our patients from our safety net population. We worked to restructure the order sets for postpartum pain management with a shift between looking at just trying to reduce pain, you know, the smiley faces, to really having functional outcomes as our goal. Can you get up? Can you move? Can you do what you need to do? Not, is your pain zero? Because, you know, really, there's a new mom, a new baby, they're confused, maybe I shouldn't have any pain, et cetera. And so we actually looked at our data 6 months before and 6 months following the negotiation, really one-on-one, working with docs, working with the nurses to operationalize this, and saw a 40% reduction in the use of opioids in the hospital, which I think is just a tremendous victory. Not for us personally, but for the women that we're caring for and their children. So that was really an exciting outcome for us. It sounds like a simple thing, but changing culture in a medical environment is difficult. Changing the patient's expectations also is challenging, and we have almost 87% compliance with our providers, and saw that very huge decrease in utilization. Interestingly enough, you will say, well, is it just that everybody's living in more pain? That is not the case. No change in pain scores. Are people taking a whole bunch of other stuff? No, that didn't change either. So I think both for women who have a vaginal birth versus a cesarean delivery, we were able to see significant decreases in the use. There's still a lot of work to be done, but I think this is a pretty significant chip and something we can all be proud of that we were able to operationalize. The second thing, so to shift gears, I'd just like to briefly, I'm also the director of the Women's Health Institute, so I've been busy standing up subspecialty services for the women of Travis County, including services for pelvic floor dysfunction, like I said, urinary incontinence, fecal incontinence, pelvic organ prolapse, patients with vulvar disorders. Yes, we said vulvar in an open forum, and patients with chronic pelvic pain. These are conditions that are associated with some shame and difficulty in talking about, particularly not only for us, but also for our patients. And many women suffer in silence. I like to say some of these disorders you don't think are really a big deal, like they're not cancer, but until you have them, right? And then they suddenly become a much bigger deal. So we have created care pathways for our patients. And the exciting thing about those care pathways and this focus on social determinants of health is that we really invite in the whole person, because we're able to surround the patient with the services that may be determining their experience of pain or their experience of, let's say, urgency and frequency, having to run to the bathroom all the time. We know that obesity affects these disorders. We know that depression affects these disorders. We know that offering patients physical therapy and less invasive treatments are often very effective. Until we formed this clinic and were able to provide those wraparound services, patients really had options to go to the emergency room or have a surgery. Two ends of the spectrum. It's not to say surgery is not a good thing, but they couldn't really access some of the less invasive treatments that are highly effective. So we've had a high number of MAP and sliding scale fee patients in our clinic who have benefited from this, and we are also committed to measuring how they're doing. And our outcome data collection is a little bit, in its infancy, but as of our third quarter, we can say that 65% of our patients said they were improved or very much improved. And of those, they took less visits than they did before we implemented these changes, and our surgical interventions are lower. So I think that that's a real win. It's extremely exciting and gratifying to be, this is the first time as a physician that I really have information on how my patients think they're doing in an aggregate. And so we're really thrilled about that, having that information and being able to serve the population of the women of Travis County in those ways. So thank you very much.
Well, thank you all. I appreciate that. I'd like to open the floor for any questions from our board members. Julie?
So I have a question. You mentioned that you have 87%, I think, provider compliance, which resulted in about a 40% reduction in opioid use. If you had 100% compliance, what would that reduction be? Do you know?
I don't think that that would be.
Close to.
I mean, 100%, I don't think it would make a huge additional difference. I think what we need to do now is to focus on the scripts that women go home with, and other interventions and opioid prescriptions that we are given for a variety of reasons. We do have a policy that I think is pretty innovative within the UT Health Austin institution around opioid prescribing and its use as part of our clinical pathways to, obviously people need opioids for some conditions and for some postoperative things, but we've really tried to be innovative in how we couple that with non-opioid treatment. And we're unified within the institution behind this policy. So do I think bumping from 87 to 100% is going to drop us another 10? I don't think so. But I think that there are lots of opportunities to continue this. I think getting to people when they're young and having their babies and saying, gee, you really didn't need a bunch of, Percocet to get through the cesarean delivery, you do just fine. It's about starting that culture early on, I think.
Thank you.
Thank you. Madam?
Yes. Well, thank you all. Thank Dr. Pino for all of you coming here. I'm a big fan of DelMed, and I'll definitely continue on supporting it. And I really want to reiterate to the community the value, because everyone's questioned, what is the value of DelMed? And this is available on your website, I believe. And one thing that is evident in our work, especially with community care, you've been able, because of DelMed, recruiting top-tier physicians to treat our patients, our safety net patients. And one thing that I love about your study, Dr. Pannone, is treating patients with dignity and respect and informing our patients. And they have the equal access of care as anyone else, not just because of their socioeconomic status. So I think the value of where we're at is definitely we're moving in the right direction. Our community is much healthier than what it was in the past. And I know that as claims as DelMed is a startup, there has been some hiccups, but fortunately that we can move on forward and attune to our community, because the medical school is built by the community for the community, and to really continue on re-emphasizing that and the needs of serving our safety net population and delivering equitable care and access to our patients in our community. So I encourage everyone to read this snippet of the impact of where DelMed has really proven to our community, and it's available on your site. And maybe we can tweet it out as well. You have? Wonderful. Again, thank you for coming here, and thank you for the work you do for our community. Appreciate it.
Thank you very much. Any other questions? Cynthia?
Hi, how are you doing? Thank you all for being here, and thank you for presenting to us. I appreciate it. I just wanted to know whether or not you all would ever consider having this type of presentation to the public. I think that would be a very good idea, considering you receive our public tax dollars to the tune of at least 35 million plus whatever else we give you through ourselves or through the CCC. And so I think that's an important thing for you all to consider, because for so long a period of time, the University of Texas was disconnected from this local community. And so I want you all to please consider that. And we'd love to help set up a forum for that to occur. I want to thank you all for being here. I could have used y'all about 27 years ago. But it didn't happen. And regardless, I'm glad you're here, and I'm glad you're working with us. But one of the things that I want to make sure that doesn't happen, because I'm a big fan of community-based organizations and things that have been working, have been a part of our system for so long, you know, such as community care. I thought I heard you say that y'all are going to be also offering primary care clinics, and I wanted to know whether or not that was going to be in competition with our existing clinics, or is that in tandem with them? Because the one thing we don't want to see, and I still do consider the University of Texas an institutionally racist institution, okay? Until they can prove to me that at the top, they reflect our Texas demographics. They're not aligned. And that also comes at the medical school. If your staff isn't reflective of our demographics, that's something we also need to contend with, especially as we're trying to grow culturally and linguistically competent doctors. And that reflects in the teaching. And so modeling is also most important for achieving that goal and closing that disparity gap. So with respect to the provision of services and the provision of care to our community, which is one of the reasons we supported Proposition 1, because we were going to work to complement what existed, not reinvent, not duplicate, and not take over. Is that something that y'all are
Absolutely.
looking at?
And the model is very much in tandem. So what I didn't talk about earlier is we've co-recruited a number of primary care providers with community care. And, you know, it's been both a great thing for, I think, the community care provider group, but also a great thing for our university to have the opportunity to do that. And most of the primary care we're providing at this time is in partnership with our FQHC partners, not only community care, but, you know, all of the FQHC systems. It was important to me that we have once we decided to have some clinical presence on our own campus, that we have a primary care clinic there as well, because I didn't want us to just have a series of disconnected specialty clinics. I really see, as much as anything, to model that we can do that all in the same space. And, you know, one hope is that we can be an innovation lab for not only our, FQHC partners, really for all the providers in Travis County about new ways of delivering care that are more patient-centered, more equitable, really use technology appropriately and meet the needs of our patients. So, I think there's plenty more to do, and your points are really well taken about our need to both encourage equity in our health outcomes, but also diverse provider training. And I think we're making good progress in that area, but I don't think we're done in that area.
No.
Much better.
And I just to add, in women's health, I think we work very, very closely with our community partners, UC, Blaine, Peoples, and have really worked hard not to replace any of those services, but complement, and also partner about trying to increase the capacity in those originating clinics as well, so that once patients are treated and stabilized, let's say for chronic pelvic pain, that we aid our providers to maintain that health when they return. So we don't view ourselves as a home for those patients. We view it as a way to augment the services that are already being provided. So that's true for us too.
Thank you.
Thank you. Still, one more thing, with respect to community-based organizations, because you allude to that in your paperwork. I'm familiar with who you have. One of the reasons that we as a community, as the Austin community, the Travis County community, especially communities of color and poverty, looked at the University of Texas coming here and supporting our entity and our partners, our providers, in the provision of those services, is that we would work with the community, also the community. That means the community, the local community-based organizations, to develop, augment, and improve strategies to reach those hard-to-reach populations, to help to close those disparities gaps. Because we had been fighting that issue historically, and we're hoping that y'all would be here as a resource for those community-based organizations. But in some occasions, or at least some concerns that I've heard is that have been at times maybe some concern as to whether or not the University of Texas or the medical school, rather, the University of Texas, I'm talking about the system, the group here, at least local, the flagship university, with its various departments. So it would be the medical school or the School of Nursing or the School of Social Work, et cetera, et cetera. What we didn't want to see happen was that your departments ended up being applicants for local grants, for local contracts that had heretofore been provided to community-based organizations, as opposed to, we're going to take in some community-based organizations to our system and then compete. And that takes away from the historical organizations that have been here. It doesn't support it. It takes away from it. And we don't want to see that happen because there are still huge disparities gaps. And I live in a world that believes there's room for everybody at the table. But you're not going to have everybody at the table unless they're all welcome. They're all not just invited, but eating the meal. Okay? So it's not enough to invite somebody to the table. Unless they're sitting at the table with you, then those entities become the meal, if you can understand that. And so that is something that we do not want to see happen. And I'm just fuel for thought, but I do want you to consider, or maybe we can have an offline conversation as to seeing whether or not that is in fact happening or not. And if it is not, then I think in addition to your little brochures is that we have not worked in competition for our local-based community organizations, and that we have in fact augmented what is occurring here. And I'm just asking you all to please consider that and wonder whether or not you all had heard those concerns. Because one of the things we had asked for originally was that there be a community advisory committee, that it would be made up of the community, that not just people or entities selected by the new people to Austin. And the new people to Austin was the medical school. So if that's anything that y'all could consider and communicate to us.
Let him answer.
Yes, sir.
So we do have a community strategy team that has been informing a lot of the work.
I'm familiar with them.
That DelMed is doing. I think also the creation of this local affairs position is because DelMed wanted to have a better relationship and knew it needed to have a better relationship with organizations in Austin. Because people have been working on these issues for a very long time. And there's a lot of rich knowledge in our community that can benefit from the expertise of DelMed, but we need to make sure that we're working in tandem. And I know DelMed wants to do that, and I think they're making steps to do that, but there's always room for improvement. I'd be happy to talk to you offline about other ideas on that.
I appreciate that.
Thank you very much. Appreciate it.
Do you have any cards?
Any other items? Okay, thank you very much for your presentation.
Thank you very much.
Appreciate you coming and talking to us tonight. Okay, agenda item number 7, receive and discuss a presentation on the proposed fiscal year 2019 budget for the Community Care Collaborative. And I've got John Morgan and Jeff Knodel speaking. Sarah. I guess I don't. I have Sarah. Have Sarah and Mr. Morgan.
I'm joined by
Dr.
Dr. Hernandez, and we won't let Jeff Knodel escape either. He's
okay, so
part of the team.
He has a seat at the table.
Part of the team.
Thank you very much.
Thank you. You ready for us?
Yes.
Great.
That was nice.
Thank you, sir. So tonight, the four of us are going to present the CCC FY19 budget. This is the second presentation to the Central Health Board in different venues. We also recently had our CCC Board of Directors meeting for an initial presentation, to talk more about what our process and next steps look like at the end. Just to set the stage for this presentation, I'd really like to start with just a review of our strategic plan and the organization's mission. I think you all are familiar with it. This board does adopt and approve the CCC mission as well as the strategic plan. And we really want to emphasize how the CCC work and the work in the FY19 budget directly supports the Central Health Strategic Work Plan as well. You'll see a lot of parallels as we work through this presentation. Sorry? And you should have in your packet, thank you, Sarah, you should have in your packet or on your table a copy of our strategic plan as well as a detailed version of our FY19 budget, and I think maybe one or two other documents. There are also a lot of slides that are included as backup or part of the appendix to our presentation. There's a lot more information in there that you're welcome to dive into, and we're happy to take questions or have discussions with individual board members if you have questions on any of that material. In terms of the four strategic focus areas, I really just want to spend a little bit of time on this slide. I'll try to be brief. I know the committee's a little behind schedule. Building an integrated delivery system for us is really about two things. None of these strategic focus areas have changed, but I do want to hit a few highlights here. In terms of building an integrated delivery system, the two main things that we focus on are building pieces, putting pieces in place in our system that are missing. You heard about some of those already this evening, from colorectal cancer screening to the women's health services that the medical school provides. We've added the hospice services you heard about earlier. This also takes the form of our service expansion initiatives like ophthalmology that we talked about earlier today. This is also about building the data infrastructure for our system. For us, that's really been a focus on the organized healthcare arrangement. It's our data sharing structure with our providers. Over the course of 2018, we've really worked closely with all of our providers to ingest system-wide data on our patient population, and we're working towards, in 2019, being able to provide that data back to our primary care providers so they have more actionable and relevant data on their patients from a system-wide perspective. Redesigning coverage programs, it's been mentioned a few times tonight, but this board in 2018 approved the creation of a program that we're calling MAP Basic. MAP Basic provides the essential services that's needed for our larger population, what is today made up of our sliding fee scale patients. And it also gives us a standardized structure and a platform that we can build on. Today, there are limitations in what we can do for our sliding fee scale patients because they're not enrolled in a formal program. That work is underway right now. Kit Adney-Spells is leading that work for us. She's here as well tonight, and we're looking forward to, in FY19, rolling out that program and starting to put it in place. Improving value in care, I'll spend a little bit of time in a minute talking about our primary care agreements, but really value in care for us is about several different things. It's about making sure that the right services are provided in the right locations and that we don't have inefficiencies just due to how we provide services and where we provide services. It's about measuring the effectiveness of our programs, and you heard the medical school representatives tonight, Dr. Rogers and Dr. Pignone, speak about patient-reported outcomes and really starting to measure how we're doing, not just from a clinical outcomes perspective, which is important, but also from a patient perspective, how patients feel about the care that they're receiving and whether they're achieving the functional benefits of whatever services that they're getting. The other part about value for us is evolving our reimbursement models, and I'll go into a little bit more detail on that in our primary care slides. We kind of saved the best for last. None of the other things that we talk about here matter if we're not improving the health of our population and getting better outcomes as a result. And we'll highlight a few of those things as well. And there are some examples, again, in the appendices to this presentation that we're happy to address with any board members. But There are a few things related to the mission metrics as well as our quality outcomes that are in that appendix, so I would encourage you to take a look at it. We've had conversations for a long time about building some of this infrastructure, and for the first time on a lot of these areas, we're able to report, we're able to prove out these pilots, and we're actually starting to see some impressive, measurable, significant results. This is a high-level overview of the detailed document that you have in front of you for our FY19 budget. I'll point out just a few things here. The first is we really tried to take a zero-based budgeting approach this year, meaning that we are really looking at what we are using in our budget, and with a goal of making sure that we don't have resources that are sitting around that are not being put to use. So really that second column, the end-of-year estimate, is what we used as our starting point, so that we made sure that we don't have budget line items that are over-allocated going into 2019. Something else that will be new for you based on the detailed presentation is we really tried to group our work by service line so that you can really understand where the dollars are going, what services they're contributing to, and it's not just the contractor. We will have to get to the level of detail of every contractor and every NTE, not to exceed amount in those contracted, those budgeted line items. We'll provide that detail in subsequent meetings. A few other things I'd point out here. One is our member payments line is a combined line right now. Both of our member organizations are determining their budgeted amounts for contributions in 2019. But in aggregate, the numbers that you see for the end-of-year estimate in 2018 and the proposed budget for 19 are about what we expect to receive in both of those years. The other thing I'd remind you, and we've had discussion on this before, we've had some changes related to the DSRIP program that affect our budget. Mainly that's a timing difference that is made up of two different things. One is this new DSRIP program is more performance-based, which means more of our expenses happen towards the end of the year as our contracted providers reach their goals. A lot of this is about clinical quality improvement. The other thing is that the first DSRIP program was in line with our fiscal year, and now it's a calendar year. So that's why you see some pretty significant changes to the DSRIP amounts at the bottom of the page. Overall, this is a growth budget for us from a end-of-year estimate perspective. We're able to apply about an additional $4 million in expected revenue sources, and then about $11 million in additional that are anticipated for FY19. So for primary care, we've really been working closely with our partners for the past few years to transform the way that primary care is viewed and the way that the CCC reimburses for care. One of the things that we're really excited about is the success of our alternative visits, which I think many of you are familiar with. Unlike a traditional at the CCC, we have the flexibility to reimburse for things that traditional payers might not. An example of that is nurse and MA visits. We think that engaging the full care team in care delivery and letting everybody work to the top of their license helps us from a lot of different perspectives. It helps us with access, because only the patients that need to go see a physician, go see a physician. People that need to go see a nutritionist, go see a nutritionist. Not everything is focused just on the physician. It's on the full care team. It helps us drive down costs. It helps us create new access in the system. Primary care metrics. There's a slide in your appendix that I'd refer you to. We're very excited about the progress that we've made. FY18 is the first year that our 4 main primary care providers all have dollars in a pay-for-performance category in their contracts. So we have dollars that are at risk for clinical quality improvement. And we've had some significant success this year. Community care, just from the beginning of this year, has improved their diabetic foot exam rates by almost 17%. The hypertension, the blood pressure control for our diabetic population at community care has increased 6%. So we think really the combination of having the right partners the right reimbursement model and the proper incentives in place, the ability to engage the full care team, we're really actually starting to move the needle on some of these clinical outcomes. Another big change for FY18 for us was we've really started to do more work related to health management. Care management, case management work happening at the CCC, happening at Seton Healthcare Family, and then also at our primary care providers. This year has really been an infrastructure building year for us, and Mark will talk a little bit more about that later in the presentation. In FY19, in terms of primary care, what we want you to know about, and these are just a few of the highlights in terms of initiatives going into 2019, the new DSRIP program really becomes the cornerstone of our clinical improvement program. There are 27 clinical measures that are part of this new DSRIP program, and it is very heavily weighted on performance improvement. So we're really excited about that, working very closely with Jason and his team, as well as our other participating providers in the DSRIP program. Something else new that we're exploring for 2019 is the addition of dental services through Lone Star Circle of Care. They have a site in Travis County that they're interested in building out dental capacity that could serve both our patients that go to Lone Star as well as other providers. And dental is one of those places that we pretty much need all the service we can get at this point. Healthcare for the homeless, you all are familiar with the Pay for Success project. We've included a line item in the primary care budget for Pay for Success in 2019. That gives us an opportunity to continue to evaluate that project. And as we've mentioned before, that initiative will be coming back to the Central Health Board before anything's finalized. We also have an additional amount in our pharmacy budget going into 2019. One of the very basic or essential benefits that we've included in the MAP basic program is a standardized pharmacy benefit for those patients that are in sliding fee scale now. So we have a pharmacy budget that accounts for that. And just one graph that helps to tell the story of what we've been working towards in primary care over the past few years. What we want you to take away from this is we're serving more patients in a primary care setting than we ever have before. And through these different reimbursement models and working closely with our provider partners, we're able to drive down the average cost of care as we're doing that. So serving more people and keeping our budgets the same and decreasing our cost of average visits. I'll be followed by Sarah to discuss urgent care.
Sure. I know that urgent and convenient care is a theme that we've talked about, much as we're looking for alternative visits so that we can ensure that our providers are able to spend the time with the appropriate level of patients. We also want to ensure that we have the appropriate mix of service sites for patients so that the choice doesn't simply seem to be primary care or the emergency department. We know there are other times when folks need care. And so as you've heard, we've really expanded our network and expanded access to urgent and convenient care services. We've contracted with new providers and expanded our reach. And in FY19, I think you'll really hear that we are trying to increase utilization in these services. As John talked about, we worked on sort of zero-based budgeting, and we haven't seen the utilization of urgent and convenient care that we would hope to, or that we might have anticipated, all other things being equal. So in this last quarter of FY18, as part of our patient engagement strategy, we're going to reach out to folks who use urgent and convenient care, understand what worked well for them, try to understand, too, some of the limitations that folks may have encountered so that we can do a better job in FY19 of driving folks towards that service when it's appropriate for them and when it feels comfortable. Similarly, we hope to roll out a new service using digital urgent care, logging on your phone, essentially on your smartphone, to see a provider, who then will be able to both diagnose and prescribe for common conditions. I know that I have colleagues, or we all have benefited from this service at the CCC, and folks have used it for things like strep and flu. So it's really able to get service in the comfort of your home. It's care to you, right? And so we're working with our friends at Ascension Seton and the Good Health Clinic there to line up that service. And we're also very excited about our pilot programs to understand how digital urgent care can be used. We think that this could be a great benefit to our community health paramedic partners who are going out to encampments for the homeless in the far reaches of Travis County and be able to connect our MAP patients there with a provider immediately. Saves folks journeys, saves folks the hard times of getting to a clinic. And we also believe that we can utilize this with our medical management team and over at Community First. So we're both excited about the broad application for our entire MAP population, and looking forward to using this on some specific populations that we feel could teach us a lot of lessons about where this service is able to be utilized.
All right, I'm gonna talk a little bit about specialty care, and they told me to go fast. So the medical school, however, did me a big favor, because they talked about half of what I had to talk to you about on this slide, so we'll go quickly. In terms of the FY18 highlights, we kind of already talked about how we've cleared the ophthalmology waiting list for MAP. We've asked for and received from y'all some additional funds to finish out the year, so thank you for that. Complex gynecology and the musculoskeletal IPUs, you kind of just heard about complex gynecology, and our work with the musculoskeletal IPUs continues. ENT network expansion, so this year was the year we brought another partner into play, Austin Regional Clinic, to help with ENT. That is going successfully. We've added additional clinic days, and we obviously have proposed that in the next budget, and we want to continue to do that good work with our partners there. The colonoscopy pilot, so we've been dutifully scheduling colonoscopies, and we're ramping up, but I'm going to talk to you about a shift that we're suggesting for FY19. And then palliative care, so separate of hospice, we contracted with a group to provide in-home palliative care to individuals for whom that's appropriate care. And so that program has begun, and we'll provide you more of an update on that soon. That's a very new program for us, but we are actually rendering services on that contract now. FY19, so let me talk to you about what we're doing with GI, and it really deals with both of those first bullets. As Mike talked about, or Dr. Pignoni that was up here previously, he is creating a pivot in the way that we're going to do colorectal cancer screening for our population, which is to move away from colonoscopy as the initial screening test and move towards fecal immunochemical tests, or FIT testing, as the initial screen. Now here's the reason for that. We've been successful in our colonoscopy pilot of completing people through the notion. So i.e., we identify a person, we refer them to the colonoscopy, the pre-colonoscopy clinic, they go get their procedure, and we're done. About 70% of the people referred actually make it through the program. That's really high, but it's not 100%.
Right.
We have people who are falling through the cracks still and not getting screened. FIT testing is much cheaper, and it allows you to screen the population as a whole. There's a lot of people that need testing, and we got to get them all screened. It identifies those individuals for whom cancer may be present. There is some abnormality that is causing the presence of blood or other chemicals in the stool that we can test. Those people need colonoscopies. Those people need an advanced test in order to ascertain whether they have a polyp or some other issue. The other problem is, and so I'll talk to you about why I'm packaging this conversation, is we have a really persistently long wait time for gastroenterology services. And that's been a persistent problem for any of you who've been on the board for a while. We've talked about it. We need to fix that. We spend a fair amount of money doing colonoscopies, but we can actually take that budget that we used for colonoscopies last year. We can take a much smaller piece of that budget and do FIT testing on everybody, particularly because Dr. Pignoni's group is also doing FIT testing on that same population. So our dollars end up going a lot farther because he's been able to bring state dollars into the bucket. And then we can reallocate the balance of that money towards actually improving general GI care for our population, and we're working with the medical school on that. They are actually in the process of doing a recruitment for a GI division chief so that they can build up their gastroenterology IPU, which can provide services to our patients. So we feel like this is kind of the best of both worlds. We can potentially improve our screening rates, at the same time really address this backup in general gastroenterology. Rheumatology expansion, you've heard bits and pieces of this because you've approved different parts of it. We have begun the kind of subject matter expert model inside of community care, where we have primary care doctors who are receiving additional training in rheumatology and are able to provide some first-line rheumatology care to patients who appear to need it. Meanwhile, there is a rheumatologist that has already been recruited jointly by the medical school and community care that will be starting, I believe, in August or September. They're finishing up their fellowship and then will be arriving to begin practice. And that person will have a significant amount of their time in community care, providing rheumatology care. We'll continue the subject matter expert model. Both will be needed. But we really think this addition of additional rheumatology care will really help us with another persistent backlog, and so that's why that sits there. And then e-consults, we talked to you previously about how we're pivoting vendors, but e-consults remain a foundational piece of the way that we want to deal with our challenges across multiple specialties and how we can grow capacity without necessarily needing to expand the number of physicians that we have involved. So that's kind of what we're doing with specialty care. Mike stole my thunder here on this slide, but I'm going to just touch bases. What you're looking at is system performance. So CCC system performance, MAP and sliding fee scale patients, and what you're looking at is months on the bottom of that graph. It's basically the rates of colorectal cancer screening in our population. Now, I will fess up. The top number, when you get all the way to the right of that, is 33.97, call it 34%. What is our goal? Our goal is the same as HRSA's goal, 80%. That's what we want. That's what we consider to be adequate, is 80%. So are we there yet? No, we're halfway there. However, you can see from this graph, we have made great strides at actually improving the rates of colorectal cancer screening, and the slope on that line is pretty close to straight up. So we are feeling really good about our ability to continue to mobilize resources to make sure people get colon cancer screening. And I think we'll move through
Can I
that.
jump in?
Yeah.
So something else that I'd just like to make the board aware of, part of the work of FY18 for us was Dr. Hernandez standing up the CCC's medical committee. 2 years ago, we wouldn't have been able to show you this information. There's been a lot of work from our quality side of the house to make sure that we're measuring clinical effectiveness, clinical quality measures, and we're doing so in a standardized fashion across our system. We have this same measure being collected the same way from all of our providers. And then Mark, with his medical committee, is able to review this and provider-specific performance on a monthly basis. Then we can have real-time conversations with our providers about what needs to be improved and how to go about that. So just wanted to go back to that piece of infrastructure building that was done in FY18, and now it gives us a tool to work with. Sarah?
Specialty behavioral health. I can't say too much with integral care in the room because I'm certain that they'll come in and exactly, or maybe I should do your presentation for you as we've experienced earlier. You know, the big piece of this is this integral care contract that we have that has been so successful. And actually, could you toggle to the next slide?
Sure.
Just to show you, in FY13, I think this was when the CCC inherited this contract from Central Health. Over the course of those 5 years that you see indicated, we've worked so closely with our good partners at Integral Care to improve performance, to expand the number of people that we're able to serve through this, which provides not only inpatient psychiatric care, but now extended observation, getting people the right service in the right place, right? And as you can see, as we've started to implement these changes, the number of people that we've been able to serve with the same amount of money has increased. Furthermore, with all of these options and working with Integral Care to ensure that case management is provided post-hospitalization, our inpatient length of stay has gone down. We've been able to, I know you've heard this before, but we've been able to have weekend discharges. We're ensured that people go home with their medications. Great performance, so a real big success story in specialty behavioral health. Also interesting, Dell Medical School was talking about opioid use disorders. Well, we're addressing that in a number of different ways in our community. One way is through expanding our substance use disorder services with SIMS, which tends to focus on our creative class here in Austin. Over the course of this year, I think they've lost a few members to opioid use disorders overdoses. And we've been able in this past year to provide them with more resources to provide more services of that type. And furthermore, on the same trend, we've launched our medication-assisted treatment pilot for opioid use disorders. You have a primer that was in front of you on your desk that sort of lays out that project. It's wonderful. We just got featured on Spectrum News. Thank you. I think we're expecting a couple other press articles about it, and there's a little video on that on the Central Health. But fabulous program that's providing an opportunity for people to decrease their dependency on opioids and be able to live a fuller life. And again, that's another project for which we've partnered with Integral Care and Community Care. So moving forward, we'll keep our good work with Integral Care. They're doing so well on the quality measures that we figure it's time for some extras, some additional ones in there. And then also our medication-assisted treatment, we're going to continue it. Today, there are 54 folks enrolled. We have space in the budget next year to add an additional 80. I think that we get to close to 150 enrolled in that program. We also believe that it's one of the programs that we can really do a rigorous evaluation on, so we're excited about that. And we're just continuing to ensure that those important substance use disorder services are available to people for whom they haven't been a priority in those services.
All right, so on post-acute care, in fiscal year 18, we deployed a care nurse into Del City Medical Center, and so our nurse basically lives over there in the hospital all week long, basically assists the existing hospital staff with coordinating discharge planning, making sure patients have their meds, making sure they're connected to care management, either inside of the CCC or inside of our partner organizations, as well as going down to the emergency department and being able to advocate for patients who are down in the emergency department who probably don't need to be admitted, but because there appears to be no connection to resources, emergency room doctors often make the default judgment, I'm just going to bring this patient into the hospital. We're able to intervene in real time and tell that emergency room doctor, unless you really feel that medically this patient needs to be in the hospital, we can get them connected to all the resources they need. They don't have to be in the hospital today. And we've been successful at being able to divert some of those admissions. By the way, nobody wants to be in the hospital, and so the patients appreciate actually having another pathway other than having to go into the hospital. They also need to feel secure that they're not going to get dropped if they're going to walk away from the emergency department, and our nurse is able to be there and help connect them to our own case management, to the FQ's case management. Of course, we have expanded our skilled nursing facility network and have both improved the length of stay at the hospital, but have also then now worked at improving our length of stay in the SNFs, because that becomes our work once the patients get moved into the skilled nursing facilities. We talked about earlier that we've had increased utilization of our hospice services, so I won't belabor that point. In FY19, one change in the way the budget is structured for this year, previously we had separate line items. So you had a line item for hospice, you had a line item for post-acute SNF, you had a line item for recuperative care. We're not doing it that way. Hospice remains on its own line. The reason why it gets its own dedicated line is because it's part of DSRIP, and we want to make sure that we have funds reserved to support that important piece of work for us. But the rest of the funds are kind of pooled now. The reason for that is because besides SNF and besides recuperative care, we're bringing some additional services online this year. We're bringing home health services, so the notion that we can provide skilled nursing or other sorts of therapies in a patient's home when that is the appropriate thing to do. By the way, it's always the cheaper thing to do than to put them in a facility. We need to begin to take advantage of that, and that actually offsets part of our skilled nursing facility cost when it is appropriate to do so. And then secondly is we need to add respite care, and if you don't know what respite care is, respite care is that notion, and the specific part of respite care that we're talking about is you have an individual who's experiencing homelessness, they've gotten to the end of a hospitalization. For anybody, you would say you no longer need to be in the hospital. It's okay to discharge you. It's not that they have a skilled nursing need, anything like that. Except that we know that at the time of hospital discharge, people remain in a fragile state. They may not actually need a skilled nursing facility. They actually do need climate control, especially in summer in Austin. They actually need to be assured that they're going to get to eat regularly as they continue to recuperate from their illness. These sorts of needs need to be met in some way, and right now, we don't have an easy way to do that. If we put them into skilled nursing without a skilled need, we're way overpaying. Put them into a skilled nursing facility, the cost is much, much higher. We actually need access to respite beds, somewhere that that patient can go and be boarded, where they have a roof, climate control, food, and the ability to kind of be sheltered from homelessness while they continue to recuperate. That's a missing part of the system. It's a part we actually got to get right if we really want to begin to affect the healthcare, the outcomes of individuals experiencing homelessness. So we're adding that as well. And so now we're going to have these kind of 4 options: respite care, home health, skilled nursing facility, recuperative care. And the funds are flexible. So the dollars that are in that budget need to be allocated to those areas based on the medical management staff's best notion of this is what would serve this patient best. This is what would serve this patient best, as opposed to us trying to figure that out with line items. Because inevitably we'll get the lines wrong. As we add these new services, there's the potential for savings, still providing the patient the absolute right place that they're getting their care. So these 2 new options will help move those dollars more efficiently into care.
And just to put some context around that from a dollars perspective, I mean, when we're talking about somebody spending the night in the hospital, you're on average in the state of Texas is around $2,000 a night, up to $2,500 a night. When we're in a skilled nursing facility, it's between $300, $600, $700 a night. We can provide home health services for a couple $100 a visit, and have people in the comfort of their home. We can provide respite care for a small fraction of what it costs to have somebody in a skilled nursing facility. But today, that's our only option. We want to increase the availability of these services, introduce these services. We're making a pretty big bet in our budget that we can see more people, we can continue to serve people, do it more effectively and efficiently, and spend more dollars along, or spend fewer dollars along the way.
So lastly, I just want to touch on the health management strategy. So, the purpose of health management is optimize the health of the covered population. It is the mission of the CCC. It's why we're here. How do we do that specifically? So we're not talking in this particular example about direct provision of medical services. This is not about the doctor. This is really about how do you wrap other services around patients so that you're addressing all of the issues, social determinants of health issues, health literacy issues, and whatever the issues are that end up being barriers for people being able to get to optimal health. How do you identify what those issues are, and how do you put the right intervention into play? We do that in several ways, and we've made an example of some of the ways in which we do that. So in the CCC, we have a medical management department. We begin that work with hospitalized patients even before they leave the hospital through our transitions of care nurse and that program. We identify highly complex patients, we bring them into case management and provide home visits from our case managers, our community health worker, our social workers, to ensure that we understand what a person's home circumstance is or lack of home circumstance is, and that we're able to rally the appropriate resources to their need. We look at operational support of projects through the medical management department. They help us with other projects that could help in social determinants of health. So those folks are very skilled at that work, and they end up having great ideas to help us drive other projects like food insecurity projects or transportation projects. Medical management staff is very invaluable in helping us understand how to create those projects. Community care. So community care provides care management services to our patients on our behalf. It's part of the contractual arrangement we have with them and the partnership we have with them. They use a clinic-based tiered system, so they have embedded case managers in their clinics. They identify patients at different tiers of severity and then apply the appropriate resources to those patients based on their tier of severity. They also have the complex primary care clinic that's new starting in this calendar year, where they have a specific site. It's over in the old clinical education center that sits next door to the old Breckenridge Hospital, where they see the most complex primary care patients, either referred from their regular primary care clinic for an amount of time and then back to their home clinic, or as an ongoing continuity experience if they're very complex and you can't get them fixed, so to speak. Then we're beginning to partner with Ascension Seton, in particular with the Good Health Center. So I'm sure you've all heard at one point or another about the Good Health Center. They have a lot of digital initiatives. You heard briefly earlier about the digital urgent clinics. We're also looking at other projects like remote patient monitoring. Those are additional tools that we can bring to bear where we can manage people's health without them actually needing to be in our geography sites. And that's very useful for patients who have transportation difficulties, who need to be monitored very regularly, so it becomes burdensome for them to have to come into the clinic every day. Nobody can do that. So how do we make sure that we're still caring for them when they actually need a touch daily? There's ways to do that.
So my apologies, I'm sure we went a little over our allocated time. We can obviously sit up here and talk for hours about the work. We wanted to try to focus on some of the highlights, both from FY18 and for FY19. This is a proposed budget. We're not asking for any action tonight. We'll be back in September with the specific action, the request to adopt the budget for 2019. We're happy to follow up with any or all of you individually offline if you have questions, or we're happy to take any of those tonight as well.
And on that note, we can also utilize the message board as well for public conversation. It's a tool for you as well.
Thank you, Mike.
I was just going to ask, with respect to what Mike just said,
You're short.
would it be possible then for us to make that a substitute for what we perceive to be important questions, and unless it's like extremely important, can we use the message board to converse with these instead of that, for right now?
Yeah, and what I would recommend is if you can post the questions if you want, probably best to send them in.
So that we see it.
Yeah, and then that way we can post them and get the answers out there at the same time. Help us coordinate and better utilize staff resources as well. Thank you.
Okay, thank you, John, Sarah, Dr. Mark, appreciate it. We're running low on time, so I'd like to recognize Shannon.
Yes, consistent with what Member Valdez just said, I think that we've had the opportunity to look at this a lot and to discuss it. So I'd like to make a motion that we limit the discussion by our board members to 5 minutes per member in order that we might be able to discuss this, and then get on to the next item.
I think that's a reasonable motion. Do I have a second?
Second.
Okay, I have a motion on the floor by Mr. Jones and second by Manager Greenberg. Any discussion? Autumn?
Not related to that motion, sorry.
I'm sorry?
Not related to that motion, I just had a question.
Any discussion on the motion? Ms. Fallon?
I thought that what I was actually suggesting was a substitute for asking the questions here. And so I apologize. I appreciate him asking that, making that motion, but I was wondering whether or not he would allow for a substitute motion to be submitted by me, and that was that we actually move forward in that the message board will be used to ask and answer our questions at this time, because we have seen this information, and we can just move along.
So let me interpret your motion correctly, or what you're saying, is that there will be no discussion and question
That's
and
right.
answer
Right.
this evening. All of the questions and everything will be placed on the message board, posted, and then there will be answers associated with that.
So how does that work legally?
Let's pause for a moment here from council.
So, because you haven't put it on the floor yet,
Yes.
he can withdraw his motion.
Yep.
And we can go with her motion.
Okay.
It's acceptable to me.
Is acceptable? Okay. So you
Have
would
a
like.
motion?
Motion, go ahead.
I just
Note that Member
She
Jones
made
is
it.
withdrawing
I'll
his
second
motion.
it.
You're seconded. Okay, so I have a motion from Manager Valadez stating that we will forego discussion on this item and questions. We will put our questions on the message board and have those questions responded to by the staff. And I have a second from Manager Greenberg. Any discussion on that motion? All in favor?
Aye.
Any opposed? Any abstaining? You abstain? One abstention, Manager Musatai. Motion carries. Thank you very much. Appreciate it. I'd like to lay out agenda item number 6, receive and discuss a presentation on the proposed fiscal year FY19, FY 2019 budget for Central Health. Mr. Jeff Knodel,
Actually, I'll start off
and
while they get settled.
I'll recognize Mike Giesman.
Yeah. So if we could go ahead and advance to the second slide. You see just as a reminder, and you'll see these objectives here, this is directly from the strategic work plan that you all had adopted a couple of weeks ago. We'll use this as a basis for building our budget, but also our related business plans as we enter into the new fiscal year for new projects. The next slide, if you'll advance to that. We wanted to put this in front of you because there's a number of projects that could be funded with some of the expansion or the new initiatives, budget amounts that are in this proposed budget once the budget is finally adopted by the board. But we just wanted to highlight a couple of the strategies that line up with the aforementioned objectives. That these strategies have projects behind them that we'll be bringing back to the board, and we gave some examples over there on the right-hand column. But we wanted to give you a sense of the sorts of things, and the public as well, that we would be funding. Typically, when you see a budget item that just says new initiatives or service expansion, we felt it necessary to spell out what all might be entailed in that. Lastly, before I turn it over, Jeff, I'd like to recognize that Integral Care is here. We do have an item that has a memo attached to it that's in your packet, and they're here to answer any questions, but we'll get to that at the appropriate time.
Thank you, Mike. Jeff Knodel. With me is Melanie Miller, and we will go through the proposed FY19 Central Health budget. Again, no action, information only. So I wanted to start off with a couple of slides related to some information requests that we had at a previous meeting related around just property tax types. So you see a graph here in this slide that shows the major property tax types within Travis County. You see single-family residence are almost half of it, and then you see other categories, including multifamily, commercial, industrial, and then a small slither of other. I think these get the major categories of taxable property within Travis County. We also requested some information. If you recollect, we do a lot of work around the taxpayer impact statement, and we have different bands of information that we present, different values within those bands. And so we asked the Central Appraisal District if they could give us some information related around those bands. And so you see on this chart, by percentage, by band, two information items by band. First, the assessed taxable value, the homestead value, and that's in blue, as a percentage across Travis County. And then the orange bar is the number or the percentage of homesteads within each value band within Travis County. So you see that the band starts to the left, excuse me, to the left and increases in value to the right, related to both of those information items. And then another piece of information they supplied to us was geographic area within Travis County. And I apologize, I know this is a really busy slide, but on the left you see a map of Travis County by geographic area. And to the right you see a corresponding chart that shows by each geographic area the homestead value, both the homestead value in that entire geographic area, and then also within that area the average homestead value within that geographic area. So you see a number of areas, and I think there's a possibility our color colors may have got a little off on the map, but anyway, this is some good information and wanted to pass it on to the board.
Thank you.
We mentioned at our last meeting that we received our certified tax roll for fiscal year 19. Our taxable, total taxable value is at $189 billion. That represents about an 11% increase over fiscal year 18. You see a history of our assessed value over time, starting from 2006 moving forward. We've had a significant amount of growth in the last several years. You see that there are some flat years and slightly declining years in 2011, 2012. So it's not just pure growth. There has been a little slowdown. And then the red line is just our central health tax rate over that same period of time. You see since 2014, because of the increased values, our tax rate has decreased. The proposal that we have for 2019 also decreases the tax rate from 2018. And my apologies, this slide slipped in. It's just the same tax rate, just list the tax rate itself. And then this slide is a real familiar slide. Again, just to reiterate the tax rate, we've received our certified roll. Based on the certified roll, we've calculated our tax rate at 4.5% over the effective rate, which is the instructions that the Board of Managers gave us to prepare the Central Health proposed budget. Again, the total rate is 10.3742 cents. A real small amount of that is related to debt service. To the right, you see the taxpayer impact as it relates to the tax rate of 4.5% over effective by the average taxable homestead value in comparison to fiscal year 19 to 18. You see our increase at 4.5% is $10.82, which is a 3.2%. And then again, just as a reminder, the board took action in fiscal year for fiscal year 19 related to the homestead exemptions, the over 65 homestead and the disability homestead exemption, increasing it from $80,000 to $85,500. And just to reiterate, on the homestead exemption itself, Central Health maintains a homestead exemption rate of 20%, which is the maximum amount allowed by state law. I'm going to turn it over to Mike for a few slides, and we'll continue the presentation.
Yes. So what this shows is that there's not a lot of drastic change in between the categories of federal poverty level. You can see that the bulk of our patients are at less than 21% of federal poverty level, followed by the 50 to 100% of federal poverty level. I would note that if you look at the growth rate, though, and the bluish color is 2016 and the grayish color is 2017, that you did see significant growth in the percentage of poverty levels between 100 and 150% and 151% to 200%. If you go to the next slide. What this shows is the percentage of patients, it's not a percentage, it's the total number of uninsured population who did not access someone within the CCC primary care network. So this would be any of our primary care providers that we're contracted with through the CCC. And this is a key factor that you've seen in some of the reports that Jason has presented in terms of looking at what are the needs within an area. As you can see in the darker green color, that 1,054 to 1,966 patients, that grouping falls in areas of Travis County that we are targeting as demonstrated by our demographic report. Now, this is important for a number of reasons. One, it validates the information that you've seen before, but also as we look at capital financing for expansion into eastern Travis County, then again, this is a strong indicator. There are several factors that we look at, but this is just one of many strong indicators on where we would locate, and also justification for various forms of debt financing. Thank you.
Thank you, Mike. So, getting into a little bit of detail, and I will go quickly. So we presented our proposed budget at a previous meeting. There have been a few changes, and I suspect there'll be additional changes as we work through the process. But I've highlighted some of those changes in red, and we've stuck some notes on those. So this is our summary sources and uses statement. You see we've had a couple of changes on that. I'll go into a little bit more detail on some subsequent slides, but I'll start off on the lease revenue side. As we've worked through the process, and we still have some work to do, we've been looking at not only lease revenue, but some of the recent agreements that we've entered into related to either Brackenridge tracks and or improvements in that. So we continue to work through that. We have increased our lease revenue to $18 million, and we'll continue to work through this number in subsequent meetings. I'm going to skip over the other changes because I think we cover those changes in subsequent slides. But I want to go to the next slide and talk a little bit about some of our both capital and our projects that Central Health is undertaking in fiscal year 2019. And so what this is, there's a lot of detail related to fiscal year 2019. And then to the right, you see just projected capital numbers for fiscal year 2020 and 2021. What I'll say right up front is we are still working through these numbers. We still have some work to do, but wanted to present what we're thinking as far as numbers and what it's going to look like from a project perspective moving forward. So there are two buckets on this chart. The top half of it called operating budget. There are a few projects that we have listed in our operating budget, and they're in operating primarily because, simply put, they can't be capitalized. So, for example, we have two projects related around potential tower demolition and other demolition on the Brackenridge campus, where you can't really capitalize assets that are in place. That just doesn't work. So it's in our operating budget.
D asset.
It's a D asset, thank you. I haven't heard that term, but that's good.
Good term.
So we've de-assetted that into operating. The same with some hazardous remediation that we have on the campus. There's the necessity to do some remediation prior to demolition, and that's also a de-assetting type of project. So that's an operating. The total amount of those operating projects is estimated at $6.4 million. We then have in our capital budget, and these are actually assets you can capitalize. You see a couple of line items. So there are some operating funded assets or capital projects that we have in play for the downtown campus redevelopment. We're doing some improvements on the chiller, some utility improvements, and we expect to recover those costs in subsequent lease payments over a 9-month period. We also have, and I'm going to call a grant operating. So we have a grant related to a cost associated with a walk-in clinic at the Southeast Health and Wellness Center. And the grant covers most of that estimate. We have a little bit of operating associated with that project. And then we have operating related to buildings and IT, information technology. So we have a number of clinics that Central Health maintains in its budget through leases that were conveyed through the city. And then information technology needs. And so aggregately, that's funded at $1 million. On the actual debt side of our capital budget, there are two line items. The first is the Red River alignment, and we have an estimate for that realignment at $8.5 million. And then secondly is an estimate related around Eastern Travis County expansion. And so we're still working on that number. What it will deploy, though, is the ability for us to move quick to begin constructing facilities. In addition to that, we're looking at the purchase of what are called mobile clinics, and where we think we can deploy a mobile clinic, a substantial mobile clinic, and get out to serve areas of need much quicker than simply a bricks and mortar strategy. So kind of a double-pronged strategy related to providing services. So we will be asking, and again, I will reiterate, this number will change, but we will be coming forward in the subsequent budget processes, and we will be requesting approval to begin the process to issue contractual obligations to further these projects. And so I mentioned previously that there's a little bit more detail in some of our budget related to some changes, and this is on the expense side. So we're in healthcare delivery, and you see a couple of changes that we have in operating expenses, and most of those operating expenses, just to cut to the chase, are related to the operations of those mobile clinics. And so it would include things like buying medical supplies, as we establish locations, the site preparation work related to those facilities, security and maintenance related around the mobile clinics, in addition to the professional staff, the staff that will actually be providing the services. And then in our reserves and debt service, again, we've made some changes. So up at the top, our aggregate amount of healthcare delivery changes. We've adjusted for the de-assetting of some of our projects. So we've adjusted our transfer to our capital reserve. And then our contingency reserve appropriation, of course, is just kind of the difference of sources and uses, and so that's increased slightly. Our aggregate healthcare delivery expenses in our budget have changed from $227.3 million to $232.3 million. In our budget, we also have funding related to capital, anticipated capital requirements for Sendero. Sendero's on a calendar year, so we're looking at calendar year 2018. And so related to Sendero, looking back at their mission, it's a community-based healthcare plan that stresses improving the health of the community by providing affordable and quality health care. You see a couple of their public initiatives that they've had. They've increased vaccination, breast cancer screenings, and flu vaccinations amongst their members in a significant way. And just looking at historically the services that Sendero has provided related from their inception of 2011 through 2018, just taking some approximations, they provided approximately $470 million in services to approximately 175,000 members, and you see the number of encounters. And then another comparison that they've looked at, they always look at as a community-based plan, or what impact do they have to the community. And one of the measures that they've looked at is, are we saving the community money based on being a nonprofit community-based health plan? And so they've estimated that they're saving their members approximately $34 million as they look out across other competitors with comparable broad networks. So you've seen these charts before. We've made a couple of, I don't want to say improvements because it's all good, but enhancements, maybe that's a good word. So previously we've done 5-year forecast. One of the things that came up out of going through the 5-year forecast was, well, DESRIP ends in 2022, 2023 is the first full year, but what does it really look like after 2023? Because again, as we get out of DESRIP, and again, the impact to Central Health would be we're providing intergovernmental transfers to the CCC, who's leveraging the success they've had in DESRIP to bring down federal funds. So this is a 6-year forecast now. We started, so we look at a couple different scenarios, and we're looking at reserve levels. So these are reserve levels. The chart's the same color format that it's been in the past. The yellow line is the what we call our emergency reserve, which is in our financial policies, and the emergency reserve is maintained at 15% of eligible expenditures. And then the gray line is both the combination of our emergency reserve and our contingency reserve. And so this is what gives us our capital, our flexibility over time. And you see the trend on our total reserve line where we get to a low point in fiscal year 19, and at 4.5% over effective, we begin building our reserves back up. But then again, as the DESRIP program is discontinued, the impact to Central Health would be we're going to have to increase our member payment to the CCC to make up for that. So you see that our capital starts declining, and we still are in a declining period even through fiscal year 24. Now the other item that we've used or that we're looking at on these charts is a metric called days of cash on hand. That's an important metric also to look at as far as capital flexibility. Central Health is a AAA rated entity, and as a AAA related entity, to receive that rating, certain metrics are looked at, and one of the big metrics that's looked at is this days of cash on hand. And the reality of trying to maintain a comparable days of cash on hand to equivocate our rating is we generally would want to stay at least 100 days of cash. And I think certainly if you look at trends and where things are moving, you just want to be cognizant of the direction you're heading, the trend you're seeing, and where you end up over a certain period of time. So you see at 4.5%, you see our trend dips, and then we start increasing, and again, over the last 2 years, we dip down right to our emergency reserve levels. Same chart, a little bit different tax rate. This reserve chart shows 6% over effective for the next 2 years. and then 4.5% thereafter. So you see that we still have the same dip in 2019. We have the same increase up through 2022, but then we start seeing a gradual decline, but we end up at $34.7 million in our contingency reserve. See the trend of days of cash on hand. We reach a maximum of 184 days in fiscal year 22. In fiscal year 24, we're at 94 days. Then our last scenario is a chart that shows 6% over effective year over year. You see that we have the same trend. It's just that from fiscal year 22 on through fiscal year 24, the reserve line starts flattening out. And so you see our days of cash on hand, we maintain over, sorry, I couldn't see that last one. We maintain over 100 days of cash up through fiscal year 24. So, thank you. So again, our low point on this is fiscal year 19, and as we have a rate year over year that builds our reserves up, we get to a more level amount of reserves. So it's from a sustainability standpoint, you know, working in the area, the healthcare industry, there's a lot of change. I mean, we've seen a lot of change that's happened over the last 3 or 4 years. I think it's been real prudent that the Central Health Board of Managers has always set aside sufficient reserves to maintain flexibility. We're being stretched a little bit related to fiscal year 19. And we would want to look at over time trying to build our reserves back up to a sustainable level moving forward. The last thing that I want to talk about is related specifically to fiscal year 19. So this chart's maybe a little geeky, but it's a cash flow projection. And there are two things that you see on here. You see bars that are orange, that represents a cumulative or year-to-date cash balance. And then you see our actual cash flow for each month. And then you see the cumulative effect of that monthly cash flow in the orange bar. So since 2017, or kind of the end of 2017, we've had a little change in how our revenues flow into Central Health. Traditionally, we had a substantial amount of lease revenue that came in monthly and helped us even out our cash flow over time. Property tax is a significant source of revenue for Central Health. And as everyone knows, property tax is really just a couple of months of collections. Luckily for us, it happens in the first half of the fiscal year, but it doesn't happen the first month. So collections start coming in December, and you see they peak in January, and then you kind of see our cash balance declining throughout the year as those resources or property taxes are used over the course of a year. I'm circling the area in October and November because we're precipitously low related around cash at that time. And there are times where unpredictable things happen timing-wise on things that we don't control. A primary example would be the call for intergovernmental transfers. So the state dictates that schedule. They typically give us a 3 to 4 day window to transmit an intergovernmental transfer. Based on what we've seen that's happened last year, it's not predictable, and there were actually some intergovernmental transfers that were transmitted during the first few months. That's unfortunate for us because, again, our primary revenues flow in December, January, and the tail end of, or the beginning of February. So I'm working with our financial consultants to look at what options we have related around this. And I'll say one of the things that I'm exploring is the use of what's called a tax anticipation note. And that's simply just a funding timing instrument where you receive funds up front in anticipation of the receipt of taxes. And we know that not all government's collections work out timing-wise, so it's a fairly broadly used instrument. But I wanted to let the board know that I am exploring that option for this period of October and November. We'll continue to work with financial consultants to explore that. Generally speaking, the way I would envision it working is it would be a 6-month issue. We'd issue in early October, and we'd get through our high periods of tax collection. And around March or so, we would look at the repayment of that. Of course, there would be some interest costs and potentially some issue costs related around that instrument. But nonetheless, I think it's certainly prudent to evaluate that option to not put us in a precarious position where there's something beyond our control that we need to do and it just doesn't time out for us. Some of the intergovernmental transfers, you don't get a do-over. You have a quarterly advance, and if that doesn't happen, you have to take the steps necessary to preclude the impact of that. So that concludes my presentation. I think you've seen next steps from the previous presentation. I do want to point a couple things out, those specific to Central Health. So we are going over to the County Commissioners Court on August 14th. At this point, we have a proposed budget at 4.5% over the effective rate. We are going to present our budget on the 14th, and then we'll return on the 18th of September to the Commissioners Court for final approval. That's the Commissioners Court schedule. As it pertains to the Central Health Board of Managers, once we get back from the County Commissioners Court, we come back a week from today, the next day, to a Central Health Board of Managers meeting, and we'll have a tax rate ceiling roll call vote. So we'll be asking for action. The action that we'll be asking for is to establish a tax ceiling on the tax rate for fiscal year 19. And this kicks off, this is one of the processes that kicks off our public notification process and starts our notice periods for both publications and public hearings. The tax rate is just a ceiling. It's not a commitment that you're going to adopt a tax rate at that prescribed rate. It just, again, it's a roll call vote that sets a ceiling for the maximum tax rate that the board can adopt. And then you see the subsequent meetings that we have related around Central Health. You see we're scheduled for 2 public hearings on August 29th and September 5th. And then September 12th, we're coming back to the Central Health Board of Managers almost a week or 6 days prior to going back to the county for final approval. So the September 12th date would be the day that we would come back to request adoption of the Central Health budget and the tax rate from the Central Health Board of Managers, and then go over to the county on the 18th. So that concludes our presentation. I would, again, I know I did this last meeting, I would really like to thank Melanie Miller. She's new with our organization, and she has really stepped up and has been a great assistance to the budget process. And quite honestly, I don't know what I would have done without her. So thank you, Melanie.
Thank you.
We really appreciate it.
Thank you, Melanie.
Thank you.
Thank you, everybody. Thank Jeff for the presentation. I want to say two items before we go on. First is that we definitely need discussion on this, and I would like to ask each member to police themselves on time and realize that it is 15 minutes till 9 right now. So, and we have a number of agenda items to go. So please be as concise as possible with your questions and your comments. The second thing I'd like to throw out is that I think, if I understand correctly, when we go to the Travis County Commissioners on the 14th, we have the ability to present our 4.5% budget, but we could give you guidance at this meeting to provide a higher percentage of, to the Travis County Commissioners.
Or lower.
Or lower.
A different rate. It could be a different rate.
So, just based on looking at days of cash on hand, in the charts on page 18 and 19, or 17, 18, and 19, my thought is that the board members should sort of weigh in on whether or not we go with a 4% over effective rate year over year. 4.5%, I'm sorry, over effective rate year over year, or consider the other two scenarios so that we can consider our financial position based on that. And so, that being said, I will open the floor up for discussion and questions, but recognize Dr. Zamora.
Dr. Chair, I know we're not posted for action tonight, but I totally agree with you as far as going with a 6% effective rate. We need to protect that contingency rate and reserve, and also protect our rating. So with that, that's all I have to say. I just feel like 6% is safer.
Thank you, sir.
Yes, I certainly am not comfortable when I look out at some of these projections. Is there a way to show the county commissioners both so that they understand what's happening 6 years out at the 4.5% versus the next one that is 6% for 2 years and then 4.5?
Sure, there's a couple of different ways. One would be just simply included in the presentation as here's what we looked at, and based on presented, the board gave guidance. We typically meet with professional staff over, kind of go through our budget with them. It's usually prior to going, but it's been, I don't know if the scheduling's going to work out right. But we have the opportunity to visit with staff also, kind of inform them. So it's really just, you know, do we want to base a decision off of what we're using for a forecasting tool and including that? I know that there may be some other communication methods to work through, but I think if I understand right, you're just kind of asking, can we potentially include this in our presentation, kind of justify what we might be considering. And again, you know, these are just forecasts, these are estimates with assumptions.
But
generally speaking, you just want to look at general trends.
Right.
It's not, I mean, I'll guarantee you that on this slide, we're not going to end up with 50 days of cash.
Of course.
Or 24. It's really just what kind of trends are we seeing, and how do we want to protect ourselves up front to have a little more flexibility down the road. And if things work out where whatever we were forecasting, we have a little bit more resources, you can always lower a rate.
Right.
And
I just
then
think
the other part of it would just
understand.
be any potential regulatory or legislative
Right. I
action
understand that
to
too.
think about.
And can I ask one? So, yeah, I think it's important for, if we just presented, let's just say for discussion, 6% in a vacuum without people understanding why, what would 4.5% look like, right? I think that's important. The other question I have is, do we have any idea what the county will be proposing for its rate and if there will be an increase?
I haven't had a chance to look, and you have to read carefully.
I know.
Because you get operating, a composite, and a debt service rate, so I don't know. I think, if I remember right, the city did their presentation yesterday, Monday, and it was 5%.
Right.
Over effective is where they proposed their
These at
budget.
5%, but I'm wondering what the county.
At one point, it was a little over 5%, but I've heard it might be a little bit lower, so I'm just not sure. We can try to find out.
That would be useful information, I think.
Yes, I agree with you. Autumn?
Well, thank you, Chair. Thank you both. I don't like the position we're in right now. A budget item I missed last month's meeting. I'm looking at page 15. Under Sendera Risk-Based Capital, 20 million? Please explain.
So,
You might,
It's an
go ahead, Jeff.
well, I guess from my perspective, just real generally, that's our estimate as it relates to the capital requirements that Central Health would propose funding for. Again, they're on a calendar year, so this would be calendar year 2018.
So this is, I'm just confused. So what we approved in 2018 is 4 million. And we're looking at, for 2019, the budget presented 20. So that's just my confusion. How did it jump? I'm just trying to understand some numbers here.
Mike?
And we had to have some kind of placeholder in the budget, and if you think about the volatility and all the variables that go into the insurance market at this point, I mean, this is just a starting point. I will say there are some discussions that will be, because whenever you look at funding or capitalizing an insurance company, there's a lot of regulatory issues around this, and so we'll be in closed session where we seek advice and counsel of attorney on this matter as well.
It's just because it's already here.
It's just it's a starting point.
And going into what Dr. Zamora mentioned, I believe based on where we're at right now, the only probable option to be, because we've almost depleted our reserves, probably perhaps is 6%. I would probably favor that based on the numbers. I would hate to add that, but we're in a difficult situation. Thank you.
Shannon?
I have about 4 quick questions. So the first one is, do you have a relationship, if we went with the 6%, where we would sit with regard to other healthcare districts? A profile, what that would look like?
As far as increase or as far as tax rate?
Tax rate,
Yeah,
comparison.
so tax rate, we are, when you look at the major hospital districts, it ranges anywhere from, I think Harris is around 17 cents. There's a couple that are around 27 cents. I think, Bear County is at 27 cents.
The lowest.
Yeah, I don't know, but
And,
this increase with that.
Still be low.
oh, so we would still be lowest. And just to kind of answer a little bit further though, we do an analysis as far as what's the proportionate share of the hospital tax as it relates to all the taxing jurisdictions of all the hospital districts and counties. And we're at a little over 4%. When you look at the other districts, there's a range, but there are, it ranges from I can't remember where the bottom range is, but there are a couple of districts that are around 10%. So again, proportionally speaking, I think we're the lowest range of all the major Texas hospitals.
Or increasing it, we would still remain in that?
Yes.
Yeah, okay, that's what I was thinking. The second question is, goes back to the budget. So, over on page 14, you're talking about operating, and these red, as I recall, these are areas where I think I understand you said we would have to look at increasing to a capacity for some of the services that we're looking at, or maybe the Eastern Crescent or some of these other, okay.
Related.
Have we considered, because one of the question with regards to the Eastern Crescent is, what are we going to do with facilities that currently exist? Part of the thinking, as I understood, is that we're looking at maybe repurposing or reutilizing staff that were in like centers like East Austin or some of the other places that we contract with or we provide. Are we looking at the savings from not operating those anymore? Or do we see any savings in that effort?
We haven't had a chance to fully analyze that. I think the way that I looked at it is how can we get services on the ground as quickly as possible? And so I think that's a further analysis that we need to do. I think the way that I looked at it related to budget is what are the costs related to getting services out to areas that needed those services.
Okay, and on page 13, the capital, under the Eastern Crescent, the $23 million, that does include temporaries and facilities and permanent facilities you envision?
We're still working through that.
Okay, so
We're
that's
working through that.
And the last question is, this 8.5 redevelopment of Red River, couldn't we all just get a shovel and go out there and?
Somebody will pay me 8.5, I'll do
Your
it.
back may be a little stronger than mine, but sure.
I like that.
Okay, those are my questions.
And by the way, just so everyone understands, this is the Central Health pro rata share of the alignment.
Right.
2033 fund has some costs associated with that also. So it's more than 8.5 million. So
Well, they could help out too.
to get a couple shares.
Before I move on, Shannon, did you have any guidance with regard to the tax rate?
Well, I tend to focus on the 6%. That's where I am. And speaking of that, I'm glad you mentioned that. When we vote on this, on the next Wednesday, I think it's next Wednesday, is everyone work?
Sorry, say that again?
Next Wednesday when we vote on the maximum. Is there such a thing as a time certain that we can vote? I have sort of a conflict at that time, and I'm trying to see if I can rearrange what I have to do to be here for that vote, so that's why I was trying to get it.
Work with the chair.
We certainly could move it up if yeah.
Make it the first item.
Move that vote up.
Yeah, if we could do it at 5:30-ish, I would appreciate it if that's possible.
Okay, thank you. Ms. Houghton.
I'm going to start off with saying I agree with Dr. Somewhat, okay? So that's it on that. And then the only other, well, I have a couple of things, but this map,
Yes.
demographic map that talks about the homestead valuation per district or per area, I'd like to see a bigger picture, a bigger map. So I could really look at that and tie it together.
Now, sorry, we had it on 2 slides, and we just decided for presentation, we would combine it, but yeah, we can provide a bigger map.
And I'm not going to go too much further except to say that the reason that I'm supporting that 6% right now is because, yes, we may not be able to pare down what's being recommended to us very much more in light of the proposed or projected future needs for our population. And we still have to look at the possibility of expanding. I'm still waiting for the six month to a year cost for service for the MAP, expanding the year for MAP re-enrollment, and then maybe expanding the cap on what the MAP eligibility percentage is, and we need to look at the cost for that. And since our primary reason for existing and for being here is to provide services to the MAP population and those under uninsured or under 200%, I think that we need to do everything in our power to start looking at the consideration of aligning our budget to accommodate that population and that population's needs. I have no problem with considering alternative other initiatives that have been put forth, but the priority, as far as I'm concerned, is going to be the provision of direct services and the expansion of numbers of people that might qualify that are not yet been enrolled into MAP that should be covered. And so that's a priority for me. And if we can give ourselves a little bit of breathing room to accommodate those needs, and we as a board can really have some serious conversations around what are we really supposed to be doing and not duplicating what other governmental entities are supposed to be providing. I think we're here to complement the other governmental agencies' responsibilities. We're here to provide services to our targeted population. So I'm going to go for the 6%.
Thank you very much. Appreciate it. Jeff?
I add, so I want to go to this slide right here. So there's been some conversation about 6%. So the taxpayer impact that you see at 4.5% is $10.82. Again, that's the average taxable homestead value. At 6%, it would be $15.67. An increase of $4.45. No, it's not right. $4.85.
And that would be included in the presentation to the Travis County Commission.
Sure, we can, we typically present a chart like this, so we would do that at whatever rate we're proposing the budget at.
At 87?
Sorry, that's page.
$15.67.
I'm sorry, 15.
Okay. All right. Manager Greenberg?
Just a couple quick things. I just want to make sure that when, again, we go to Commissioners Court, that we provide all the information that's necessary. So I know in the past we provided charts that show, as Manager Shannon was asking about where we sit vis-a-vis other healthcare and hospital districts, so that will be included.
Yeah, so we're building on what we have. So we're building on what we started last year.
Right.
So we did what we called a budget book last year.
That's right.
And so we're trying to improve year over year.
Yes.
And right now, it's fair to say I'm the bottleneck on it. But our plan is that we send something over, and it'll have a lot of that information.
Right.
If it's not in the presentation, we will have a lot of information that we've traditionally shown in the past.
We can talk about the stuff, but I think some of it needs to be in the actual
Yeah,
presentation.
no, I agree.
And then on the tax anticipation notes, I mean, clearly the state of Texas does this every year, and there are other entities that do. The shorter is better because of the interest. And I appreciate seeing the capital budget item in here. I think it's important too for our partners to see that, and for Commissioners Court, and for others to know when we have more detail how we're rolling out in the Eastern Crescent. And your plate is very full now, but in the future, and I'm happy to work with you, with people on this if they so desire, having a capital improvements program in the future, just given where we're going with the Eastern Crescent.
Well, yeah, we're definitely changing.
Thank you.
As a project, but as an organization, we'll have multiple projects
Thank you.
going on.
Thank
So we'll
you.
have to get into that kind of budgeting.
Thank you very much.
Thanks, Sherry. Let me check with others.
You presciently answered my question about what that dollar amount would look like, and I think I can be okay with 6. I know we're coming back to talk about a max this week, and it doesn't mean that it will be, doesn't mean the county will accept it, but I think I could be all right with that as a max.
That's correct. That just says what we would present as a proposed.
Yep.
Right. Ms. Valadis?
The only thing I was going to offer is that tomorrow, is I think, scheduled from 10 to 12, is Travis County's first public hearing on their on their budget. So that's tomorrow.
Okay, thank you. Jeff, I think you have your guidance. Okay,
Okay,
very much.
thank you.
All right.
Thank you.
Thank you. Thank you both.
Thank you. Yes, I'd like to recognize Mr. Geisler.
So we have a couple of items that are also in your packet for the FY19 budget development. One is for a funding request from Integral Care. That is a project that is in conjunction with Austin Independent School District. Members, this is slightly different from what you see in other typical budget requests because you haven't adopted the FY19 budget, but what we're recommending, you don't need to make a decision tonight. I just need to bring this to your attention, and then we may take some motions up at the full board meeting next week. But there's been a request to help fund on-campus mental behavioral health services for Austin Independent School District. This was originally funded under a district project, I believe, and then obviously with changes in DISRIP, we're looking to continue this. Now, Integral Care has stepped up and is providing funding for this program to be able to get it started. And there's an interesting issue here related to the timing with the school district, but while Integral Care is continuing funding for this, we've been asked to participate in this. It would be for just this coming school year only. But my recommendation is at $420,000, I've been advised that the school district will also contribute some funds, and then there may be some attempts to bring in other funding sources as well. The question is, why $420,000? Because when you look at the business plan that was submitted by Integral Care, I think the costs are in the neighborhood of 1.4, 1.5 million. But when you look at the breakdown in payer source, it's consistent that around 30% of those that are served by these very valuable services are uninsured. So focusing on our patient population of those that don't have the means to pay, and then taking that percentage and carrying it through, on the algebra, you arrive at the figure of $420,000. So again, this is a one-time funding commitment that we're going to be working on, and again, we may ask you for some motions next week. The reason we're handling it this way, understanding that nothing's final until you adopt the FY19 budget, is again, we need to be able to demonstrate to the school district and to Integral Care that there is decisive action being taken here and strong direction and guidance, if you will, when it comes to even starting work on necessary agreements and contracts. So that's the reason for this particular approach and for this item. We have Hugh and Dawn here from Integral Care to answer questions. They've been waiting very patiently with smiles on their faces throughout this whole process, but I'm happy to answer any questions as well.
Questions? None?
Manager Jones.
Sean?
So is this focused on AISD?
Please come up to the table. Thank you.
I guess my question was just a brief one, so you could probably stand up and answer it quickly. But what does that mean for other school districts in terms of their population?
So currently, this project is specific to AISD because it was related to a district project that Seton was previously engaged with through AISD. And so actually it started with Lone Star, and then we jumped in and picked it up from there and saw it through to its ending point. And through the RFP process that AISD had to obtain nursing and mental health services, through iterations of discussions, the school board decided to fund, to take the full amount of money and put it towards nursing services, leaving them, the rest of the staff, to find other funding, which they feel like they can do and are continuing to do. So they're committing $400,000 right now and still continuing to look for other funding to fully. We, too, had a district project that served the outlying counties, so Manor, Del Valley area. So we actually, separate from the AISD contract through our own, so Integral Care is an IGT entity. We're able to, participate in the waiver independently, and we're serving those school districts now through that and are continuing to serve them.
Well, I'm a new board member, so I wasn't familiar with that background, so that's very helpful for me to understand.
Yes, sir.
So those communities are being served?
Yes,
This
sir.
is just
They're
the
not at
first-
risk. We're continuing those services. We're able to fund those services. This is a separate, because the AISD school district was not a part of our district project. It was a part of the district project between AISD and Seton.
Okay, that was the question I had. Thank you.
Great question. Thank you for asking.
Thank you very much. Any other questions? Okay, Ms. Valadez, I'm sorry.
I don't know if this is a question because I know that the services you provide on campuses, all our campuses, is necessary. And what's unique about AISD is it's got its recapture to deal with. But aside from that, the need is greater than we may even think, even by identifying the students that are not receiving the access to those integral care services that they need to have. So I'd like to know, is there any motion that we are looking for, at least to make a recommendation?
Not at this time. We may bring some motions
We're
back
gonna bring
to
it
you
back.
for next week, potentially.
Well,
It was
let's
just to
bring it back.
bring the issue to your attention.
'Cause I was ready to go for it.
I know you are.
Make recommendations, let's just go, okay?
But keep it in your mind and think about it. If you have any questions, we'll continue to answer those questions, but we'll bring back motions at a future meeting. Thank you very much.
Thank you.
Really
Thank you
appreciate
your time.
staying so patiently as we went through all this. Okay, it is 9:13, and I announce that the committee is convening an executive session to discuss agenda item number 4, discuss and take appropriate action on a ground lease agreement to be entered into between Central Health and Travis County Emergency Services District 11. Under Section 551.072 of the Texas Government Code, deliberation regarding real property, and items 9, discuss and take appropriate action on an update regarding Sendero health plans, including the effect of federal legislative and regulatory actions. Let's see, where am I?
It was 10, yeah.
Is that it?
And 10.
And 10, that's what I was missing. Well, it could be 10. Oh, I'm sorry. I
10.
read the items wrong. I'm sorry. Item 9, discuss and take appropriate action on 1115 Medicaid waiver, delivery system reform incentive payment projects, the Community Care Collaborative, including healthcare delivery arrangements and other related community partnerships. And item 10, discuss and take appropriate action on an update regarding Sendero health plans, including the effect of federal legislative and regulatory actions. Under the Section 551.085 of the Texas Government Code, deliberation of governing board of certain providers of healthcare services, and items 4 and 9 under Section 551.071 of the Texas Government Code, consultation with attorney. Okay.
Let's just go ahead.
Okay,
At 11.
Oh, it's like when your computer goes to sleep and times out.
okay.
Oh, no.
We need to move that to midnight on
It
meeting night.
is 11:09 and the committee will reconvene. It's 11:09, the committee will reconvene in open session. No action will be taken on items 4, 9, and 10. Item number 11, confirm the next regular committee meeting, date, time, and location. The next Central Health Board of Managers Budget and Finance Committee meeting is scheduled for Wednesday, September 26, 2018, at 5:30 p.m. Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. Do I have a motion to adjourn?
Move adjournment.
Second.
I have a motion from Ms. Greenberg, a
Thank you,
second
members.
from Ms. Valadez.
Thank
All in
you.
favor?
Aye.
Any opposed? Any abstaining? Motion carries.
Thank you.